Sometimes in the world of medicine, the most amazing stories aren't about the newest gadget or the latest discovery. Sometimes they're about an old-school, classic operation making a huge comeback. And that's exactly what we're talking about today with open renal artery surgery.
So let's just get right to the big question, right? We're living in an age of tiny cameras, lasers, and little metal stents that can fix things from the inside. So why on earth would a doctor ever choose to perform a major open operation on a kidney's arteries? It sounds like a step backward, but as you're about to see, for the right person, it's a giant leap forward.
To really get why this surgery is so important, we have to start with the problem itself. We need to talk about the kidney's lifeline, the artery that feeds it, and what happens when that lifeline gets dangerously clogged.
The condition we're talking about is called renovascular disease. And honestly, this analogy on the slide is just perfect. Think of your kidneys as these incredible high-performance engines. They need a constant, steady stream of fuel, which is blood, to do their job. Renovascular disease is like a major clog in that fuel line, and it's literally starving the engine.
And when that engine starts to starve, well, the consequences are catastrophic. We're not talking about small issues here. This can cause dangerously high blood pressure that no amount of medication can seem to touch. It leads to a slow, steady, and terrifying decline in kidney function. And in the worst-case scenario, it means total kidney failure and being tied to a dialysis machine for the rest of your life.
So yeah, the stakes could not be higher. Now, let's look at how medicine has tried to fix this over the years because it brings us to a really fascinating point. Sometimes the newest thing just isn't the best thing.
The whole story is right here in this timeline. I mean, way back in the day, the only real solution was just remove the kidney. Pretty drastic. Then in the 50s, surgeons figured out how to actually go in and repair the artery. A huge breakthrough. And then, starting in the 80s, we got the modern approach, angioplasty and stenting, where you go in with a balloon and prop the artery open from the inside.
Now, you'd think the stent would be the hands-down winner, right? I mean, it's way less invasive. But here's the twist. Major clinical trials started coming out, and for a lot of patients, they showed that putting in a stent was no better than just managing the problem with pills. This left this critical gap, a group of very sick patients who weren't getting better, and for them, the old-school open surgery was still the most powerful option on the table.
So who gets this surgery? This is the key. It's all about being incredibly selective. This isn't for everyone. The ideal candidate is someone with that really severe, out-of-control hypertension whose kidneys are failing, and failing fast. They've got critical blockages, and just as important, they're healthy enough to handle a major operation.
And this quote from the study just nails it. It basically says that the worse your blood pressure is before the surgery, the more likely you are to have a fantastic outcome. It's a huge clue that the blockage is the real villain causing all the problems.
Okay, so we found the right patient. Now what? What actually happens in the operating room? Let's talk about how surgeons literally reroute this vital river of blood to save a kidney.
Even though the actual surgery is super complex, the game plan is beautifully simple. You can boil it down to just 3 steps. Step 1, get to the arteries. Step 2, rebuild the connection and get that blood flowing again. And Step 3, which is absolutely crucial, confirm that the fix is perfect before you close everything up.
One of the most common techniques is the bypass, and the highway detour analogy is spot on. Surgeons will take a piece of a vein, often from the patient's own leg, and use it to build a brand new road for the blood, completely going around the traffic jam caused by the blockage.
Another way to do it is what I call the clean-out. The technical name is a mouthful: thromboendarterectomy. This is perfect for when the plaque is right at the entrance to the kidney's artery. The surgeon literally goes in and scrapes out all that gunk, just like cleaning a clogged pipe, and opens things right up.
And the third main approach is called reimplantation. This one is probably the most elegant. If the artery is long enough, the surgeon can just unplug it from the diseased part of the aorta and plug it back into a nice, clean, healthy spot nearby. Simple as that.
So, those are the strategies. But the real question is, does it work? Well, this is where the story gets really, really good. This is why this operation is still a lifesaver.
Look at this number, 70%. What does that mean? It means that 70% of the patients in this study who were told they were permanently dependent on dialysis were able to stop. For good. I mean, think about that. That's not just a medical outcome. That's giving someone their life back. It's incredible.
And the impact on blood pressure is just as stunning.
Remember, that was the other huge problem. Well, after the surgery, an amazing 85% of patients were either completely cured of their high blood pressure or saw a massive improvement. It's a huge win.
But we have to be real here. This is a high-stakes, high-reward situation. When the surgery works, it works beautifully. The repairs are incredibly tough and last a long, long time. But if it fails, the consequences are serious. It dramatically increases the chance of needing dialysis forever. And not just hammers home why picking the right patient and having a skilled surgeon is everything.
All of this brings us back to the main point. This isn't about old technology versus new technology. It's about having a full toolbox and knowing exactly when to use the right tool for the right patient at exactly the right time.
And this warning from the authors is the perfect summary of that idea. This is not a just-in-case surgery. You don't do a huge operation like this to prevent a problem that isn't even causing symptoms yet. This is a targeted, powerful therapy reserved for patients who are actively and seriously ill.
So, let's wrap this all up. What are the big takeaways? First, open renal surgery is not obsolete. It is a vital, specialized tool. Second, its success lives or dies by picking the right patient. Third, for that perfect patient, it can work miracles, literally reversing kidney failure. And finally, it's just this powerful reminder that progress isn't always about the flashy new thing. Sometimes it's about mastering the things we already know work incredibly well.
And that really leaves us with one last big question to think about, doesn't it? As we all keep racing towards the next big innovation, how do we make sure that these timeless, incredibly skillful surgical abilities, the ones that produce these kinds of amazing results, don't get left behind?